Okay, yeah, live. Hello everyone, I am Dr. Jasmine Marwaha and I welcome you all again in a Global Interdisciplinary Summit 2020. Earlier we had Dr. Ritul with us, now we are back with Dr. Joseph Mina Atalla. It's with tremendous pleasure that I welcome Dr. Joseph to GIS. Talking about him, Dr. Joseph became a dentist at the age of 22, then completed his dental education 3 times in 3 different countries by the age 30. He received his Bachelor of Dental Surgery from Missouri University for Science and Technology and completed his residency at Cairo University, Ain Shams University, and Alexandria Research Center. Dr. Joseph is currently involved in research at both Frankfurt University, Germany. He is both a fellow and a master of the International Congress of Oral Implantologists and was the first member of the German Society of Oral Implantologists in the United States. Today he'll be talking about immediate implants. So before moving ahead, kindly I would like you guys to visit the links in the description box. Thank you. Over to you, sir.
Hi, everyone. Thank you for having me. My lecture is about immediate placement and one of its biggest challenges, which is the transition zone. And when you place an implant, what you're trying to achieve is the tissues and the bone to try to hug the implant and stay there. You want enough tissues and bone and volume through the years to be there as much as possible. And there's always challenges, and this is what we're trying to be pointing out some bullet points on as we go forward. So after you remove a tooth and you have a socket, there is a jumping distance. The tissues and the bone try to jump and close and maintain itself as much as possible. When it can, it comes to shrink a little bit. And this is when we see the loss of the socket. And this is where we're trying to achieve all the socket preservation and bone and tissues and maintaining the bone for the tissues to be able to hug it. This is from the desk of Dr. Netwig, and it's showing here the socket and how it looks like in 0 weeks, 6 weeks, 12 weeks, and after 3 to 6 months. Tissue loss, that's our biggest challenge, especially when we do immediate implants. You end up sometimes with having a good osseointegration on the lower part of the implant, but then the first 2 to 3 millimeter of the implant have a massive challenges in the transition zone. Like we can see the difference after 10, 20 years after the implant placement. Transition zone is the small space that plays an important role. It's literally the bone and the edges of the bone all the way to the implant surface. If we're unable to achieve that the bone jumps and hugs the implant, what happens is it just shrinks. Shrinking it can be compensated by a good connective tissue that adhere to the implant, and you have a lesser problems, but throughout the years, it tends to be a little bit more extensive than that. If you aren't able to get a good cervical adhesion around the implant from the tissues and the bone, then you end up after not just a few years, but 10, 20 years with a much bigger complications. You end up having an implant that is also integrated, but the upper half of it, you're having a lot of retreatments and retreatments for peri-implantitis sometimes. Jumping distance is distance between the immediate implant and the adjacent bone. It was once believed that if the distance was greater than 1.5, bone graft was needed. We've seen a lot of literature, and there's going to be a lot of coming literature that is debating that. What we're trying to achieve is the scaffold, the bone. If we have the bone already, or we're trying to achieve the bone to be formed, as much as we can, we have to have a base for the connective tissue to adhere. We have to have this bridge for the tissues to jump and adhere and hug and have this rubber band of tissues around the neck of the implant. Basics for tissue regeneration, of course, it's growth factors, cells, and the scaffold. The scaffold is always helped by bone substitute or other tissue regeneration growth factors that can help the bone to be formed. PRF, we all know, like the interleukins, the growth factors, the insulin-like growth factors, platelets, and as long as, even though all these are available in the regular blood and our blood supply, there is a much higher concentration and best of all, the consistency of it if we're placing the implant. It can adhere a little bit better. It can form the consistency that we want for enhancing the quality of the scaffold that we're trying to achieve. Not every tissue have the same jumping capacity, the tissue stability, the thickness, the vascularity. We want the tissues to be able to hug the implant at the end of the day as much as we can. If the tissues are thin, if the tissues are doesn't have enough like underneath bone layer for it to jump and vascularity, then we end up having the tissues failing to achieve what we're trying to make it achieve with around the neck of the implant. So it does it, but it does it halfway there. We have to motivate the distance. We have to think vascularity, especially in the wider defect. All these blood supplies are like water hoses. We want it to be as many of them and as stable as they are to be able to jump on the implant. Think of implant surface areas. Some surface areas are more porous, they're more susceptible, they're more hydrophilic. As we see the MTX and Tionide and acid etch sandblasted implants, we can see recently that acid etch and sandblasted through the literature is having one of the best surface areas that are available right now. The dynamic, the aqua dynamic, the blood dynamic, how the blood supply moves over the implant. Is it hugging it? Is it attracting it? Is it sliding over the implant, or is the blood supply and the blood more reserved? The surface is not helping it. As little as value of the surface implant, like on the final, in the beginning, especially with the immediate implant and the transitional zone, it have a huge value. Attachment, formation of a new bone. We're trying to form a new bone out of thin air. We're trying to let the tissues and bone jump in thin air and try to hug this implant. This is a slide showing the acid etch implant and how porous it is. And think of the blood here. There's more than enough surface area. There's more than enough holding it and stabilizing it to start adhering more. So at the end of the day, we're trying to achieve a contact area. We're trying to achieve an osseointegration. The physiochemical and morphological methods of the implant, the modification, it's always very normal and it's very accepted to have more than implant design. And we need to be able to personalize and prioritize different objectives for the treatment of the patient. So having different kind of designs for every situation is of a great benefit, as long as you understand and you're very familiar with the implant design that you're using. Recently, I've seen the conical connection having one of the best seals ever, and least micro movement, less bacteria, less acid, less irritants around the cervical of the implant. It helps us to hug the tissues better. It is trying to move our way of thinking as the abutment from a prosthetic perspective to a more surgical step. So if we have an abutment that is sealed with the implant and is acting as one piece, then we're trying to think of the abutment as the lower half of the abutment as a surgical part, not just a prosthetic part. So consider one abutment, one time technique. There is absolutely no doubt that putting an implant and the threads being screwed in as few as possible can achieve a higher precision, less error. Having a good friction, we've discovered that it causes a better seal. It's a longer seal. The biomechanics for future loading, the long-term stability, it's affected. When it comes to the ankylose, for example, when it came up with the first conical, or true conical, we were able to think that pressure equals force by area. So by utilizing that and putting more pressure around the seal of between the implant and abutment, we were able to achieve a more forgiving error margins, a better seal. These are the different kind of connections under electron microscope, and try to understand the implant that you're using and the quality. The cervical threads, we've seen like open threads, micro threads, and we've seen no threads at all. Even though micro threads was having larger surface area in the beginning, but there was more absorption. We're trying to learn more that uh, like open threads, polished threads, we're trying to realize it have less bone loss. We're trying to think back about decreasing the micro threads again. This is the histological picture of the same implants. And you can see like the ones with the micro thread, number B, is having some of the most bone loss. Our understanding to the anatomy of the connection and the transition zone will give us a better understanding to what we're trying to achieve. If we have a better bone as a base, then we can have the bridge for the tissues to grow, for the tissues to jump and start to hug the implant. And we started thinking by the platform switching, and why if we're ever losing bone vertically, if we're ever gonna lose it, let's try to lose it horizontally. And this one we started thinking about even submerging the implant a little bit more. Submerging it gave it a little bit more stable, more scaffold, more bone volume, better support for the tissues, and a better longevity. Different kind of implant surfaces with the aluminum trioxide here. And you can see that we're trying to achieve as many or as little remnants as possible. With the ostium, the Coimlog, the Dentsply, we've been able to achieve less like alumina trioxide on the surface. Of a lesser value it is than before, but it's still of a minor value. What is the coronal seal? What are you trying to achieve at the end of the day? You're trying to achieve this rubber band of tissues around the end of the implant. The tissues needs to be tight around the neck of the implant. We're trying to think long-term. If this patient became a smoker 5 to 10 years from now, as the patient goes older, there's more bone loss, tissue loss. There is challenges that his mouth is going to go through. You can't think only for short term. You can't think of just the healthy now. What you're trying to achieve is a good rubber band, rubber seal around the neck of the implant. What kind of cervical, what kind of a surface area do you want to expose to the oral cavity? The smaller it is, the lesser chance of any infection and any acidity from the oral cavity. Yet at the same time, the surface area of the implant can achieve a more bone osseointegration. So this balance needs to be put into consideration. What is that for you? Like, is this coronal seal and sulcal epithelium, junction epithelium, and connective tissue, is that a better seal, or that an opportunity for a bigger pocket? If you're able to stabilize it, to have connective tissue and a good junction epithelium, it can work for your favor. If not, then this width and this length can act the opposite. There's always microadhesion that is very similar to hemidesmosomal like adhesion. You can't achieve this by removing and putting the abutment multiple times. You can't achieve that by different kind of crowns. You can't achieve that with a lot of cement that is escaping underneath. But do you need the volume? Is the volume going to be helpful? Is it something that is on the long term will be the best beneficial for the tissues? Absolutely, if it's healthy and you can stabilize it. Always remember, the more the surface area of the implant and the circumference of the neck of the implant that is exposed to the oral cavity, yes, it's higher and higher surface area for the osseointegration. But the more the surface area of the implant to bone, equal less bone volume around the implant. The less metal, the bigger the chance of the bone, as long as the jumping distance is not challenging enough for the implant, for the bone to be able to achieve it. So you want to have the highest number of bone, the biggest volume of bone and tissues around the neck of the implant if the tissues and the scaffold underneath it is helping it and utilizing it to be able to achieve it and jump there. So always remember, we're not trying to put an implant that lasts for more than 1,000 years, but we're trying instead to have and make sure that the tissues around it to last a lifetime. Focus more on the tissues, focus more on the bone around the implant. The dead space, the lesser dead space, will help us achieve more tissues, more live tissues. Think of it as an anchor. Are we considering going back to bendable implants? Are we considering back to one-piece implant and with less components? We're going to see the future is very promising, and we're going to be seeing a lot of different kind of prosthetic that is helping us to achieve a better quality of implants. The architecture of the implant, the design of the implant will help us be able to use smaller ones. Smaller ones, more tissues, more bone, as long as it's not thin enough to be malleable, except for where we want it to be. Build tissue volume. This is some of the ways that we use to do our implants here. And we, after the healing cap, and after you gain as much as possible from the tissues and the bone and the connective tissue, build the volume, then later on start to add and reshape and create the emergence profile. Shape it accordingly, shape it gradually. Build volume first, then start adding the pressure and the stability. Tissue volume, tissue quality, rubber band of tissues around the neck of the implant that hugs it and seals it. Try to build to compensate for the future of this patient's lifetime. This is a very, one of the interesting cases that we've done with a very thin amount of bone. We were able to achieve and place mini implant, and then we had to modify a ridge, modified ridge flap, and to be able to put the crown and sustain the bone and the tissues at the same time as much as possible. Partial extraction therapy. The one on the lower right is for the same patient, one that was placed more than 5 years ago without PET, and the other one with PET. The PET is definitely, with no doubt, is causing a good scaffold around the bone. We help the jumping distance. We help the volume. It's stabilizing the buccal bone. It's stabilizing the thin bone. And by causing that, we're able to achieve a better blood supply, a better scaffold, a better like condition for the tissues and the bone to try to hug the implant. So what are the criteria for partial extraction therapy? Root submergence. Utilize the roots as many and as often as you can. As long as the root is healthy and stable, there's no decay. Let's see what we can do with it. Socket shield, pontic shield, and proximate socket shield. This is from Dr. Alberto Misali. And here's again what we're trying to achieve. Building volume, putting the implant a little bit deeper, putting the abutment a little bit thinner, and trying to have this compressive volume and tissues around it, stabilizing it. You're trying to build this box for the tissues to grow. You're trying to have this box and bone volume for the bone to adhere to the implant, yet at the same time, you're having enough length and tissues to be able to fill in. Are we going to consider endodontic implants again at some point? We've seen PET being on one surface, two surfaces, and more. We don't want malleable implants. Yet at the same time, we don't want them to be too brittle. We want thin implants and we want to utilize the teeth and the remaining roots as much as possible. The future is very promising and it's very interesting to see what's going to happen in the next few years. Building the volume with either Fourier technique or things like bone ring technique, or replace the implant with the scaffold already there, building the implant while building volume with it at the same time during placement. We're trying to stabilize the bone. We're trying to keep the bone at the neck of the implant with the biggest volume we're able to achieve so the connective tissue can start to hug it, vascularize it, and achieve a better coronal seal. In the future, we're going to be seeing a lot of techniques for the scaffold. Materials are going to be different, porous and more stable to the implant. All the techniques that we're trying to achieve is trying to achieve the cervical implant or the cervical part of the implant to have a more stable bone, thicker bone, and the connective tissue around the implant to be a little bit tighter while having the right emergence profile, either self-cleansable or more adhering to the abutment and the crown. Axial loading and lateral loading, we have to understand that the implant and the tooth act very differently when to forces. The implant doesn't have the periodontal ligaments that we have in the tooth. Axial loading, you can see it on the tooth, tends to be spreading all around the tooth, same as the implant partially. But when it comes to the lateral loading, they act very different. Lateral loading with the implant tends to be more focused on the cervical part where the implant is placed. So with the teeth, it's very different. The teeth tends to move. There's around 25 microns that the tooth gets immersed into bone. By doing that, for the implants, lateral loading can be decreased when the implant is wider. Yet at the same time, if these forces are exaggerated on the bone anyway, then the bone volume tend to decrease through the years. So making up for it and having more bone volume from the beginning is better to compensate for it through the long term. So as a value of wider implants, there is a bigger value of having more tissues and bone around the neck of the implant. And this balance is what we're trying to achieve. And our understanding to the value of the tissues and bone volume in comparison to distribution of the forces on a wider implant. And this balance is the thing that caused us the last few years to discover that one of the biggest mistakes in implant history is how wide of an implants that we used to use in comparison to the bone that is left around it. So putting an implant is a little bit more submerged, more bone volume, even though the lateral loading might be minutely more, but there's much more to compensate with it with the tissues and the bone. Momentum. If there's a car that is stable and another car that is moving that hits the car that is stable, which one is the one that is affected more? The one that is parked, the one that is stable, the one that have zero velocity. So what is moving in our biting force? Is it the mandible or the maxilla? The mandible is the one that is moving and it's hitting the maxilla. And this is why the maxilla and the maxillary teeth in the posterior, they have 3 roots. The bed is more divergent. There is more of the trilo positioning or the dispersion of the actual forces on it. That's why they have the alveolar bone on the maxilla is more porous. That's why we have the sinus. So mass time velocity from one side and mass time velocity from the other side, we understand, and we have to put in consideration what we're trying to achieve and trying to put into consideration the forces on the maxilla in comparison to the mandible. Is it that going to be as important to having a different kind of design for an implant? No, but at the same time, we have to understand that the forces, the lateral forces, exaggerated in each can be different in each position and try to personalize it individually. Cantilevers and implants, our understanding is a little bit different now than before. um, we've been able to achieve and understand how implant act. Where are all these forces being concentrated on? Is it on the bone or is it on the screw? How can we disperse it accordingly? How can we uh, distribute it better so there is lesser forces on the bone? Bone like resonance, it doesn't like continuous pressure and it doesn't like no pressure at all. And we're able to achieve that as much as we can. This is a cantilever. It's a 3 centimeter bridge. And if you thought about the moment here, which is the pivot time length versus the other way around. So you have 100 Newton from one side and P1 is exactly the opposite. So you have P1 times 1 centimeter. It has to equal, because every force there's an equal force to it, is 100 times 3 centimeter. So P1 will have only 3 newtons if the distance between them is 1 centimeter. While on the other hand, if it's also 3 centimeter bridge and you have only the distance is 0.5, then you double the newton on P1. By understanding that, we make sure that the axial of the implant in any cantilever and measuring the distance and the PA distribution can have a better value on the final results around the cervical of the implant. So the AP spread, we try as much as we can to decrease cantilevers, but if we have to, we can do it. And understanding the distance between the X and the 2X is the thing that we'll see when we're able to do it. So how to distribute the forces, how to distribute the energy on the neck of the implant will have a huge final results on the cervical of the implant. So having all this into consideration when replacing the implant immediately, according to the depth of the implant and how the bone responds, will have a huge impact on the final results. Always remember that with a U-shaped arch, the AP spread and the cantilever, you can't have it as long as something with a narrow arch. So even though it's a U-shaped arch, even though it's a wider arch, don't cantilever it as much as a narrow arch. We're going to be able to have a better understanding to the architecture and the design of the implant. The future is going to be smaller implants. We're going to be able to achieve a better understanding to the distribution of the implants. And by that, we'll have an end result that of cases that were been more complicated before, and being able to place bigger and adding a bigger anatomy, we're going to be able to utilize it with a lesser bone. We're going to be able to utilize it with smaller implants, and we're going to have more solutions for things that were harder to find solutions for. Also remember the implant tissue supported prosthesis. If you're thinking about tissue supported versus fixed prosthodontist, this one you have to make sure that the implants are away as possible from the tissues, so the tissues can be utilized, the soft tissues. So think of it as two tables with the other, a table with two legs, and the other side is on a mattress. If there's a third leg in the middle of the table, then there's an internal stresses inside this table that can break it. So make sure that the implants are more towards, not the canine area, not behind the canine area, but more to the anterior. And that's a completely different concept. This is when you're trying to utilize the soft tissue. You have to plan it completely different than the fixed prosthesis. Validation of simplified implant cantilever fixed prosthodontist. This is a literature that have been done in Brazil, and they compared the forces and the axial forces on the anatomy of the bridge and one with a plain anatomy. And we're able to achieve and see the same thing again and again, that the lateral loading on the implant at the end of the cantilever is the problem. All these concentration is exaggerating the forces on the neck of the bone and on the screws. How can we compensate for that? If we're able to put the implant a little bit further back, if we're able to put the implant a little bit deeper, if we're able to have a better screw and a better connection to disperse the energy differently, we're going to be seeing a lot of this in the future. Like through the study, we simplified fixed prosthodontic presence, and the behavior is very similar to the anatomic prosthesis. But again, the axial and non-axial loads are compared. This second one is more damaging to all the components of the fixed prosthesis. So lateral loading, and lateral forces, again, are going to be always the problem with the implants, and how we compensate for that. Having a bigger implant decreases that on the edges of the bone, yet having tissues and bone volume can have a better impact, because on the long term, we need these tissues and bone more. Think of the implant and the tooth always when you're trying to achieve the occlusion. With the implants, you have a mechanical integration of maximum of 5 microns. And with the tooth, every time you're biting, there's a 25 microns that is immersed in the periodontal ligaments. So every time the tooth over tooth is biting, then you can have sometimes 50 microns of space. While at the same time, if you have an implant on implant, there can never be more than 10 microns combined opposing each other. So now here you have a big space where over there you don't have enough space, and all this energy and all this biting force is more concentrated on the implants, especially if there is a lateral loading or an axial side on the forces. You have to compensate that with articulating paper, and this is one of the reasons we try to separate a little bit more. Through the years, we discovered that also the tooth can over-erupt and make up for it. By doing that, we try to equilibrate the biting force and the occlusion and have a re-evaluation through the years. Tissue manipulation. How can I manipulate the tissues to have the best value and the best tissue volume? Palasha technique is one of the very common techniques, and we're able to achieve this connective tissue. Don't dispose it, whether you're using like your blade or half a punch. Try to utilize it. Try to think microsurgically, like plastic surgery. These are the different kind of techniques as well. We try to achieve the papilla and the attached gingiva, 5-6 millimeter, 4 or 5 millimeter attached gingiva, and the 3 to 4 millimeter attached gingiva. The more tissues, the lesser you're concerned about the jumping distance. And flapping the tissues to have this envelope connective tissues from the palate is one of the different kind of techniques as well. Having more vascularity, having more tissues will help you with the final results of the bone and the cervical of the immediate implant. When you have a remaining root and the connective tissue sometimes is not enough, think of secondary intensione. Have a partial thickness, reposition the connective tissue flap apically, leave it until it here with secondary intensione, and then extract the tooth, extract the remaining root, then consider placing the implant without connective tissue grafts. So this is one of the techniques that you should be considering as well. And that will be it for me. How much time did I take? Hello?
So So, sir, it was really informative and a wonderful session. And it seems everybody is appreciating you. Thank you for taking out the time to speak to us on this very interesting topic. I hope we didn't get any queries. Wait a second. Okay, we didn't
Thank
get
you.
any query. So yes, sir, it was very informative and hosting your session was wonderful. So, sir, at last, do you like to say some words?
Thank you very much. Just try to get in the global summit, and Dr. Kianor Shah is a very enthusiastic dentist, and there's going to be a lot of future surprises, and we're happy to get all the people around the world and have different perspectives to personalize more, understand more. And we're happy to have you, and thank you for having me.
Okay,
Thank
thank you,
you.
sir.
Thank you.
So we'll be back with our next session tomorrow. For more information regarding certificate registration speaker schedule, visit the links in the description box. Till then, stay tuned, stay safe. Thank you.
Thank you very much.